by the Hawk and Harrier trial, we have known that almost 52 to 56% of patients can be maintained on Q12 dosing. So case one is of a 65-year-old male who presented with sudden metamorphopsia, and visual acuity was 3/60 in the right eye. There was a very tall PED here, and one can see that just after one injection, the PED has regressed to this much, and the visual acuity improved to 6/36, and this patient is maintained with just another injection. He just received another injection of Brolucizumab and is doing well. So second case is of off-label use. It's a case of an IGT with SRNVM in the right eye, and the visual acuity was 5/60, and we injected Brolucizumab twice, and you can see here that anatomically also the fovea, how well it has actually, the fluid has regressed, and even the contour of the fovea is very well maintained over here. My third case is of a chronic CACR with CNVM in the right eye. The left eye already has a scarred CNVM over here, and this is the octa picture here. So with one injection of Brolucizumab, the visual acuity improved from 4/60 to 6/36 in this particular patient. Another patient of an IPCV here, and you can see here that after one injection, the regression of the PED. Then in DME also it has shown very good results. So I'm just rushing through this because this is not a treatment naive. The previous ones were actually treatment naive patients. This is a diabetic macular edema which was treated with with Razumab actually for 3 times with 3 doses with recurrences. And also in the left eye we had given Ozurdex, and again there was a recurrence. And after the third injection of Ranibizumab, we gave Paginex, Brolucizumab, and one can see that the regression of the edema is also very good here. This is the post-Brolucizumab picture in the right eye, and the visual acuity improved to 6/9, and in the left eye it was also regressed. So again DME, the regression was very good with one injection, although there was a recurrence after 3 months. So what I noticed was that the central foveal thickness actually, the drying effect was very good, and the visual acuity, since they were treatment naive patients, the visual acuity improvement was also very good in my cases here. So marked drying effect of Brolucizumab was there. I experienced one case of anterior segment inflammation which was treated with topical steroids, and this patient had received Ranibizumab before. One case of RPE RIP, and the patient was actually treatment naive and unfortunately a one-eyed patient. So this is the patient which actually developed a RIP over here. The PED was not very large here, but even then there was a RIP here. So patients not responding to multiple anti-VEGF, risk-benefit ratio can be explained. A recommended monthly dosing, although is recommended, but I do not follow that. We give it every 2 months, and results are much better with treatment-naive patients, and it is best suited for RPEDs, IPCV, occult CNVM, and now diabetic macular edema also.